Hello friends, welcome back to my channel Medicine of On. Today we'll talk about the diabetes in pregnancy, right? So it's one of the important topic regarding the gynecology and obstetrics. Now see the diabetes in pregnancy you can see in the woman you can get in the two stages. The diabetes that can be existed before the before gestational or before pregnancy, or the diabetes that can be found after pregnancy, right? Now see, if we classify the gestational diabetes mellitus, basically whenever we are saying the term the diabetes in pregnancy, basically we are what? We are defining the gestational diabetes mellitus, right? Now see, according to the White classification, what it is a White classification. White classification, the gestational diabetes mellitus, that can be two types. That can be two types. So we can get either type 1 or you can get type 2. Yes, type A1 and type A2. Now see, whenever we are saying the term the type A1 means whenever the gestational diabetes that is oil controlled with diet, right? So A1 means the gestational diabetes mellitus oil controlled with diet. Or I should I simply control with diet. And A2, this defines the gestational diabetes mellitus controlled with insulin. So this is the A2 classification. So the under White's classification will get two, the gestational diabetes mellitus A1 and A2. A1 will define whenever the gestational diabetes mellitus that will be controlled with the diet. And A2 whenever the gestational diabetes mellitus that will be controlled with insulin, right? Now another type that is known as pre-existing or pre-gestational diabetes mellitus or overt classifications. We can write it over here. Okay. So another one is over here. That is the pre-existing or overt. Now in these cases we can get the different types, right? First we'll write down this one in terms of B, C, D, okay, F, C. Oh. So we'll get in these cases B. If we get to see the diabetes mellitus that is for less than 10 years. C, if we get to see the diabetes mellitus for 10 to 19 years. D, whenever we will get to see the diabetes mellitus that will be for more than 20 years. F, whenever we will get to see the diabetes mellitus that is associated with the nephropathy, right? So along with nephropathy. The classification of, for example, over here R, that means the diabetes mellitus associated with a retinopathy. And H, that means the diabetes mellitus associated with heart disease. Okay, so these are the classifications in terms of the pre-existing or overt, and in terms of the White classifications we'll get to see the gestational diabetes mellitus. Okay, now it's important to know for us that why we'll get to see the development of diabetes in pregnancy. Why we'll get to see the development of diabetes in pregnancy. Now see, basically the gestational diabetes mellitus that will be found beyond 24 weeks of gestation. Beyond 24 weeks of gestation. So highlight simply the GDM. Okay, GDM stands for the gestational diabetes mellitus. The gestational diabetes mellitus basically that will be found beyond 24 weeks of gestation. Okay, now why beyond 24th weeks? Because after 24th weeks we will get to see the secretion of one hormone from the placenta. So what is the name of that hormone? So after 24 weeks we will get to see the secretion of one hormone that is known as HPL. Why? What is HPL? HPL is nothing but the human placental lactogen, right? Human placental lactogen. Human placental lactogen. Now see this human placental lactogen, this hormone is having that what the insulinase activity. That means it can destroy the insulin, right? Insulinase. Whenever it is having the property of the insulinase, so definitely the insulin product, the amount of the insulin within the blood that will be less. So ultimately the sugar level that will get increased. Okay. See, not only the HPL, but also there are many hormones. For example, if we say in terms of the estrogens or the growth hormone, right, or the cortisols, they are also responsible to activate the insulinase property. Okay. So what are the other hormones over here? So we can see in terms of the estrogen, we can get to see the growth hormone, also the cortisols. So they are all of them are responsible for the activations of the insulin property. Ultimately, we'll get to see the insulin that will drop and the sugar level that will get increased over here. Okay. Now there are many classifications as far as the diagnosis is concerned. Okay. So at first I'll go for the screening test for the gestational diabetes mellitus. So how can we do the screening test for it? Okay. So anyway, let's continue. Has some network issue, so I stopped the video over there. Now see, at first I said the screening test. In the screening test, in non-fasting conditions, we have to give 15 gram of 50 gram of the glucose. After that, we have to check for the glucose values in the blood. So within 1 hour, if we get to see the value is less than 140 mg per dl, that will considered as the normal blood sugar level, right? But if we get to see the blood sugar level after 1 hour only more than 140 mg per dl, so for that thing we have to go for another confirmatory test. We're in doubt, we cannot say exactly yes the pregnant woman is having diabetes, right? Now another is over here, after 1 hour if we get to see the value is more than 200 mg per dl, for that thing we can say yes is the diagnostic for gestational diabetes mellitus. This is the screening test, right? So another test that is also done, that is known as glucose tolerance test. Okay. Or that is the diagnostic test. So you can say diagnostic test, or another name for it, the glucose tolerance test. So in these cases, basically in fasting conditions, in the fasting conditions, we give near about 100 gram of the glucose, 100 gram of glucose. After that, we should go for the what glucose, the value of the glucose within the blood. Now, okay. So after 1 hour, for example, if we get to see after 1 hour, the value is, for example, less than 180. After 2 hours, if we get to see 165. After 3 hours, for example, if we get to see less than 145. If any of these three, two are positive over here. For example, out of these three, more than equal to 2 are satisfied. So we can say yes is the diagnostic for gestational diabetes mellitus. Any of this? Okay. And of course, you know that if we get to see the after 1 hour, the value is less than 105, less than 105 mg per dl, that will be considered as the normal. And another test as we do over here, that is what American Diabetes Association test. That is classifying the diabetes in the two types, type 1 and type 2. As you know, in type 1 we'll get to see that what the beta cells will be destroyed over there. Okay, so we'll get to see the deficiency of the insulin, and in type 2 we'll get to see the resistance of the insulin receptors. Ultimately we'll also get to see that what increase in the sugar values in the blood. So here basically this is known as on-step test. And in these cases, in fasting conditions, Basically, we give 75 gram of the glucose. It is very important. Okay, in medicines, only 75 gram of the glucose, and after that, we go for the sugar value checking. Now, if we get to see after 1 hour, if we get to see the value is less than 92, it is very important. So, we'll consider this the normal. This is the normal, okay? And if we get to see, for example, after 2 hours, the value is, for example, near about 180. And after 3 hours, for example, if we get to see the value is 153 near about. So, any of these two, if we get to see positive over here, any one of these two positive, that means they're satisfied. So we'll go for yes, is the gestational diabetes mellitus. Now another kind of the test we basically do in terms of pre-gestational diabetes, right? So if we get to see, for example, any woman who has come to the OPD and she is saying, yes doc, I don't have any kind of the symptoms of the diabetes, so why should I go for the testing of the diabetes? But the thing is over here, for example, by chance, if she can develop the diabetes mellitus, for example, pre-gestational. So what type of problem we'll see in the first trimester, there will be more amount of the more congenital anomalies, because in first trimester we know that most of the organogenesis that will take place. So this is known as pre-gestational test, for example, in terms of diabetes. Basically, here we go for HbA1c test. The value should be less than 6.5%, and we also go for serum fructosamine. The value is, normal range is 258 to 288 micromole per liter. So this is a normal range, right? Now, what is the main purpose of testing in pre-gestational test for the just to clarify whether the pregnant lady is having diabetes or not. In these cases, the main thing is about here, more sugar that will proportionate to the congenital anomalies. So more sugar that will cause more anomalies. Just to make sure that thing, we should go for the pre-gestational test. Okay. Now let's discuss about the complications from the maternal side and from the neonatal side. Okay, so what type of the complications we'll get to see from the mother's point of view, and what type of the complications we'll get to see from the fetus point of view. Okay, and also neonatal point of view in these cases. Okay. So let's talk about those things over here. Now see, the complications from mother's point of view, as in the gestational diabetes mellitus, the size of the baby that will be large. So large baby over here. So large baby, if the size of the baby is large, so in that cases we have to go for the more usings of the instrumental, instrument. So we can, in the first cases over here, the instrumentalations, that will be increased over here. That means we have to use more instrument. Okay. Number two over here, we have to go for a cesarean section. Cesarean sections, that will be also increased over here. The third thing, we can get to see the birth canal injury. So in these cases you can also get to see the birth canal injury. We can also see the postpartum hemorrhage. Another complications, postpartum. Another important thing, whenever the fetus or the baby that will come out at the time, we can get on congenital anomalies. that is known as shoulder dystocia. Shoulder dystocia. So what are the complications we can get in terms of mother point of view? So if any mother is having the gestational diabetes mellitus, as a result we will get to see size of the baby or the in this cases. So any pregnant woman who is having gestational diabetes mellitus, okay, the fetus or the baby, whatever you can say, the size of the baby that will be increased. So whenever the size of the baby that will be large, for example, so if the size of the baby is large, in that cases we will get to see different kinds of the complications. First, we have to use for more amount of the instrument. Second thing, which over here we can go for the cesarean sections, right? The third thing we can get to see the birth canal injury. The fourth one we can get to see the postpartum hemorrhage. The last one is the congenital anomalies, that is the shoulder dystocia. Okay. Now we'll talk about from the neonatal point of view, what are the complications we can get to see. Before that, the other complications we can get to see in terms of the mother, that is the polyhydramniosis. Polyhydro. Okay, let's see this part. Polyhydramniosis. So in these cases we will get to see basically chorioamnionitis. Chorioamnionitis. The other complications we can get to see over here, that is the preterm labor. The others, in 25% of the gestational diabetes mellitus pregnant women, they are having chances to develop the hypertension and also the abruption. So what these are the complications we can get in terms of the mother's point of view. So whenever the size of the baby that will be large, so we have to use for more instrument over here. The second thing, we can get to see the birth canal injury, we can get to see the postpartum hemorrhage also over here. We can get to see also the congenital anomalies, that is shoulder dystocia, right, over here. And apart from that, we can also get to see the polyhydramniosis. In these cases, we will get to see the chorioamnionitis. Okay, in 20% or 25% of the gestational diabetes mellitus women, they are having the chance to develop the hypertension. That's what I have written over here, and also the abruptions. Okay, now we'll talk about what are the complications from the neonatal point of view. It's very important. So neonatal complications. Now see, so what type of the complications will get in terms of the neonates? So in terms of the gestational diabetes mellitus, the pregnant woman is having more amount of the sugar within the blood. So more amount of the sugar that will also reach where within the fetus. So the fetus is having the healthy pancreas, right? So the fetus that will try to compensate by producing more amount of the insulins. Okay, so whenever the more amount of the insulin that will be able to metabolize the glucose that will come from the mother. So as a result, we will get to see the size of the baby that will be increased, right? Now another important thing is over here, that the pancreatic beta cells that is trying to compensate, right, by secreting more amount of the insulin. As a result, ultimately we can get to see the beta cells hyperplasia over here. Okay, so that's what I'm going to write right now over here. Okay. Now see, in neonatal complications, we'll get to see the first thing is over here, we'll get to see the hypoglycemia. Why we'll get to see the hypoglycemia? So the mother is having more amount of the glucose that is not getting utilized. So from the mother's body, that is not utilized. So not utilized from the mother, that will reach up to the fetus or reach to baby, whatever you can say. And see, whenever it will reach the high sugar that will reach up to the fetus, so the fetus with the fetal pancreatic beta cells that will start secreting more amount of the what insulin. So in these cases we'll get to see the insulin level that will be increased, that will be increased over here also. So whenever the insulin level that will be also increased, so here we'll get to see the metabolisms of sugar. So whenever there will be the metabolism of the sugar properly, so we'll get to see the large baby. That's why I wrote in this, over here. In this case, see the large. You will get to see the large baby. Large baby over here. So whenever we are getting the large baby, so this type of the complications will get over here from the mother's point of view. Okay. Now, for example, once the fetus has been delivered, so whatever the problem we'll get to see. Okay, so after born of the fetus, okay, the fetus will have the tendency to secrete more amount of the glucose. The neonates will have the tendency to secrete more amount of the insulin. But whatever the glucose the fetus will or the baby will get from the mother, that will be utilized, right, properly. After that also we'll get to see the some amount of the insulin that will be remain over there, because in these cases we'll get to see the development of beta cells hyperplasia, pancreatic beta cells hyperplasia. Okay, so that's what we'll get over here in terms of the neonatal complications. So let me repeat once again, this is a very important thing. So in terms of the neonatal complications, we'll get the hypoglycemia. In terms of the neonatal complications, we'll get to see the what hypoglycemia, because in the mothers the more amount of the sugar that what is not getting utilized over there, that will reach up to the fetus, and the fetus that will start secreting more amount of the insulin. So whenever it is secreting more amount of the insulin, we'll get to see the metabolisms of the sugar. As a result, we'll get to see the large baby, right? Once the baby has been delivered, okay, the tendency of the neonate, the pancreatic beta cells that will secrete more amount of the what insulin, but it is not getting enough amount of the sugar from the mother, for example. As a result, it will make, with respect to the baby's fetus, with respect to the baby's pancreatic beta cells, the pancreatic beta cells is secreting more amount of the insulin, right? But it is not getting that much glucose as much it is getting secreted from the pancreatic beta cells. So ultimately we'll get to see the development of the what hypoglycemia over here. Okay, and we'll also get to see the beta cells hyperplasia. What are the complications we'll get? Okay, whenever we're getting to see the beta cells hyperplasia or hypoglycemia of the neonate, so what are the congenital defect we can get to see? Let's talk about those things. Okay, so whenever we'll get to see that hypoglycemia over here, so along with the hypoglycemia we'll get to see the development of hypocalcemia, okay, hypocalcemia. We'll get to see also hypomagnesemia. We can also see the polycythemia, because the bone marrow that will be stimulated by these conditions. Okay, whenever the bone marrow that will be stimulated by these conditions of the baby, so we'll get to see the polycythemia. There will be the productions of the more amount of the RBC. So we'll get to see polycythemia. So whenever the polycythemia will be over there, so we'll get to see the hyperbilirubinemia. Hyperbilirubinemia. So in these cases, try to understand the sequence over here. So what are the complications we can get? We can get to see that hypoglycemia, we can get hypocalcemia, we can get hypomagnesemia, we can get the polycythemia, because in these conditions the bone marrow that will be stimulated and the bone marrow that will start secreting, or the productions, or the bone marrow that will start productions of more amount of the RBCs, that will lead to the polycythemia. And whenever we'll get to see the polycythemia, that will end up in the result of what hyperbilirubinemia, right? Now, other complications in terms of the congenital anomalies. So, in terms of the anomalies, what other thing we can get over here. Okay, let's talk about those things. Okay, so in terms of the congenital anomalies, we can get to see the problem in terms of heart. We can get to see the problem in terms of the neurovascular problem. Let's use this one for you. And we can get to see also the cataract. Among these three, the most common complications will get where within the heart. Most common site of complications or the anomalies, whatever you can say. So most common anomalies will get to see in terms of the heart. So whatever of the anomalies we will get to see, that will be the transpositions of the great vessels. Transpositions of the great vessels. So the most specific anomalies within the heart in this condition will get, that is transpositions of great vessels. In pediatrics, I hope you have read these things. Transpositions of great vessels. So this type of the complications we can get to see in terms of anomalies in terms of the heart. Okay. What about the neurovascular problem? In terms of the neurovascular problem, we can get to see the neurological manifestations. For example, we can get to see the encephaly. We can get to see the spina bifida. Sometimes we can get to see the sacral agenesis. Another important thing that in terms of the heart we'll get to see that the transposition of the great vessels is the most specific and the most common one, but along with it we can also get to see the VSD, the ventricular septal defect, the atrial septal defect. These things can also be seen, but the most specific on that is the transpositions of the great vessels. Okay, so these are the complications in terms of the anomalies in baby. Okay. Now we'll talk about the management. So in terms of the management, let's double check. How can we manage the patient? Okay. See the management. First, if we get to see the medical nutrition therapy, we have to go for the medical nutrition therapy. Okay, if we get to see that by giving the by proper dieting, if we get to see the woman is having not that much kind of the problems or the complications, so the first management that will be medical nutrition therapy. In these cases, basically, if it is controlled with diet, so in these cases we have to give, for example, 50% of the carbohydrate, 50% carb, 30% of the protein, and 20% of the fat. And in terms of the the calorie, so if we say in terms of the calorie, so normally a normal woman, she is supposed to have 35 to 40 kilocalorie per day. Okay, but in these cases we have to give for only 25 to 30 kilocalorie per kg per day, for example. So this type of the calories would have the a woman, if she wants to remove the problems, for example, the different kinds of the complications from her, so she should obey this type of the diet chart. Okay. Now, okay, another important thing, yes, that I must mention this one. That we have to examine the fundus of the woman. Okay. So in these cases we have to check the fundus of the eye, because in these cases we can get to see the development of the retinopathy. So out of within the retinopathy, that 80% is the background, and within the 20% we'll get to see the new vascularizations retina, new vascularized retina. So 80% will get the background, the vessels, and in 20% we'll get to see, and in 20% we'll get to see the new vascularized retina, new vascularized or retina. Okay, new vascularized retina. Now, for example, see in this case, in these conditions, we have to examine the fundus, and if we get to see the 20% new vascularized retina, in that cases during the pregnancy, during labor, or during perturations, during labor, the intraocular pressure, during labor, the intraocular pressure that will be increased, and that can cause the detachments of the retina from the blood vessels, for example. So that can cause the detachments of the retina. So cause detachment of our retina. Now see, what did I say you? That in terms of the gestational diabetes mellitus, we have to examine the fundus. So because in these cases there is a chances to develop the retinopathy. 80% is the background, okay, and within the 20% of the cases we'll get to see the new vascularized retina. So whenever new vascularized retina will be over there, so during labor the intraocular pressure that will increase so much that can cause the detachment of the retina. Okay, so that's why before pregnancy, so before delivery, we must examine the fundus of the eye. Okay. Okay. Now let's go for the drugs. So what are the drugs we can use in these cases? So drugs basically, as we know that drug of choice, of course, it will be insulin, and you can also use the oral hypoglycemic agent. But the drug of choice in this case is the drug of choice and drug therapy. The first line drug we should use over here, that's the insulin. That is the most effective drugs over here. Most effective ones. Apart from that, you can also use for the oral hypoglycemic agent. We can use also oral hypoglycemic agent, and in that cases we can use glyburide. We can use glyburide, or we can use the metformin. Metformin, the first line drug. So what did I say? In terms of the drugs, we can use the drug of choice, that will be insulin. That's the most effective one. Apart from that, we can use the oral hypoglycemic agent. We can go for glyburide. We can use also the metformin over here. Okay. So in terms of the management, and in terms of the delivery, there's also very important who is the timing of the delivery in these cases. Okay. So for example, if we get to see, okay, if you get to see the woman, he is in the stable conditions. The woman is in the stable conditions by proper dieting. So the delivery should be around 41 to 42 weeks. Now if you get to see that the woman, okay, the pregnant woman, she is oil controlled with drugs, then you can go for the delivery. For example, for 38 to 39 weeks, right? If you get to see the woman, she is oil controlled, she is not oil controlled, for example, then we should go, so the time limit should be less than 37 weeks or more than 34 weeks. So these are the timings. I am repeating once again. The timing for the delivery in these cases we'll get to see if the woman, okay, is oil controlled with diet only, then the pregnancy, the delivery should be within 41 to 42 weeks. If the woman is oil controlled with drugs, then the delivery should be approximately within 38 to 39 weeks. If the woman, she is not oil controlled after using the drugs as well, so the pregnancy should be at less than 37 weeks or more than 34 weeks. So these are the managements in terms of the delivery, in terms of the for controlling the blood sugar level in the gestational diabetes mellitus. Okay. And okay, another thing, what should I say? What else? Like, okay, most of the parts are covered. And in type 1 and type 2, yes, another important thing, in type 1 and type 2 diabetes mellitus, if you get to see, okay, for example, any women who was having the, for example, type 2 diabetes mellitus from 5 years ago, and after 5 years she is conceiving for the first time. So in that cases, the pregnancy should be terminated by 30 less than 37 weeks. By less than 37 weeks, yes. So it will be more than 37. So in terms of the type 1 and type 2, in type 1 and type 2, it's not important, questions are not asked from this point, from this topic, I mean from this statement, that in type 1 and type 2, when the pregnancy should be terminated, that is more than 37 weeks. But the most important thing, what I said, that if the woman is well controlled with drugs, if the woman is well controlled with the diet, if the woman is not well controlled with the drugs as well as the diet, so what are the time limits for terminations of the pregnancy? Those are very important and the potential questions in the different medical entrance exam. So keep watching, keep learning, and if you are new, please do like and subscribe my channels, and see you in the next video very soon. Thank you for watching.